there was some earlier summary that had been developed over the last, I guess, year or so since all of these other work groups throughout several iterations of the meetings. And so I'll just read the executive summary of that group, or of the group here. And so ultimately that reads as, for the ML/AI model creation and implementation work group, the regulatory guidance will be a balancing act between being highly specific to a unique type of algorithm that serves a specific purpose, and B, being generic and high level enough to not answer concrete questions. So the current guidance is a monolith that groups all of these diverse algorithms and purposes together, which is likely no longer representative of the future landscape. So during this work group session, we want to discuss AI, clinical uses, the volume of data needed, and also potentially discuss ethical concerns, performance issues, and what type of value proposition that AI models can glean. So providing guidance on how AI can be trained and evaluated, and as well as performance on, or discussing performance on how algorithms are trained, evaluated, validated, implemented, etc. And then, so I'll kind of open that up to everybody and see everybody's thoughts on how to start the discussion. But anybody have any thoughts? So
maybe we want to boil it down a little bit finer.
Sure. Well, ultimately, I think what we want to try to get out of the work group session is, I mean, essentially that is the ultimate deliverable, right? So we want to discuss how those are relevant in today. So that's kind of what's being the focus today. So it is a huge topic, right? I mean, we're not gonna be boiling the ocean and thinking that we're going to be able to resolve all of it tomorrow. But the questions of how AI is used in clinical practice, what the volume of data is needed, and how people can actually, or how labs can start perhaps training and evaluating those models in for their own clinical use cases or for specific intended uses. So I guess, does anybody have comments on how AI should be used clinically today, and how we should be training / evaluating those models in practice? Or what type of guidelines that can be set forth in this kind of pre-competitive space?
I guess maybe it'd be helpful to start possibly with like thinking about how we determine which models we actually, decide to start training and think about deploying. Like, what's that process like now?
Well, deciding which models that are thought of as being trained is really, I guess, up to, there's millions of different, it's up to whatever the clinical question of interest is, or the research question of interest is, right? So if you have a clinical question, then you're going to try to pick a research tool to then figure out what you want to train, and then that's where you start figuring out which data to look into. That's going to be based on availability of data, access to data. So maybe we can start with, is anybody using AI in their practices today or in their research today?
For research, yeah, but even there, I mean, it's almost like it's too broad to start with. So maybe if we could focus in on more narrower scopes of AI related to digital pathology. I mean, we could even start with something like differentiating segmentation from object detection to anomaly detection, because there are all these different types of strategies. And I imagine some questions might be a little, or some answers might be a little different depending on what context you're talking about.
Yeah, but so I feel like that's going to be based on the clinical question, right, or the research question of interest, right? So some models or some clinical questions are going to be based on detection. Some are going to be based on classification. Some are going to be based on. So I mean, are you detecting tumor, or are you classifying grades of tumor? Are you detecting some type of microorganism, or are you training some unsupervised clustering for some features that we don't even know exist today? So I think it really depends on the clinical interest or the clinical question, not even clinical, whatever it is, the research or question of interest, and then framing the decision support tool or wherever it may be around that question. And I think a lot of that is going to be governed by the data, the access to data, and I guess other resources that may or may not be available to the researcher or the person who's looking into all of these, trying to train these models. And then there's the larger question of how do we evaluate pre-trained model performance? There's discussions of federated learning or being able to, there's a lot of questions on generalizability, which I think hasn't really come up as much in the clinical. I mean, it's come up, but it hasn't really, there really are no guidelines or validation guidelines that have sprouted out to say, if I am a researcher, if I'm a clinician, pathologist, etc., and I get this pre-trained model, what do I have to do to embed it in my workflow and validate it and show documentation that I've tested this and it's safe, it has efficacy for patient care? Because ultimately, even though these start as research, we want to translate these into clinical practice, or for most things.
Yeah, I think the idea of like sharing pre-trained models is super interesting. There's also, I mean, like you said, there's the question of like, how do you evaluate a model that was trained on someone else's data? And then there's also, I think, like some privacy questions. Like in some cases, it might be possible to do some kind of like adversarial attack on like a pre-trained model to actually recover some of the data it was trained on. Like we see that in some language models, for example. So, those are maybe some types of things that could be more in the scope of like regulatory in terms of privacy for federated learning and sharing models and stuff like that.
No, that brings up a good point. And then also in terms of performance over time, so kind of performance monitoring between data shift or different trends that where there are changes to the system, how to monitor those and make sure that there's revalidation or maybe recalibration for any changes in those systems. I think we probably can discuss what type of guidance would be. We don't need to solution everything today, right? But we should probably come up with what is needed to bridge the gap between what we have today and where we want things to be. So if the goal is to say we need validation documentation or validation guidelines to support clinical implementation, and well, there's two things, right? There's the regulatory aspect and being able to clear these models. And then the second is how do we actually use these or take them from a research or vendor space and be able to validate them clinically. And so being able to actually have the regulatory oversight, which essentially clears the vendor to say you can use this based on what your claims are, versus the professional and or accreditation organizations to say this is what you need to do in order to clinically use this or actually bill for this test, in a sense. So any thoughts on either segments of those?
So is that one of the takeaways that hopefully we come up with a few ideas for suggested experimental design in regulatory documents? Or?
Yes, I think if we can we can draft some points or comments to say, you know, this is where we think, or this is some recommendations on where we think regulatory guidance can help the pre-competitive space, whether it's industry or whoever's in the research space, to say this is what we need to move the needle and actually start developing these types of models for clearance, versus the clinical space, which is dealt with the accreditation bodies, the professional societies.
Yeah, I think one thing that's pretty interesting is like the regulatory process for like approving a model for use, and then, you know, the model's in production and you're monitoring its performance over time. And then maybe it'd be useful to lay out some guidance for like how to tell if your model's performance is dropping for whatever reason, and then actually how do you decide if you want to, you know, retrain your model or fine tune it with new data, and then what's the regulatory process for that? Is it the same process as, you know, the approval process in the first place, if you're like updating the model, or, you know, how does that fit in? That could be something to, you know, give some guidance on.
Yeah, so the FDA does have the software as a medical device for AI proposed workflow that is available. Currently, they're kind of included, they're in this planning phase, or so the pilot phase was what, 2 years ago now, where they were able to go with some large industry leaders, and they looked at 5 main segments from a corporation standpoint. They're talking about patient, the general quality of that company, or quality assurance of that company, cybersecurity. So they had these 5 points of excellence that they looked at as the company as a whole, and they didn't even look at, you know, the actual AI models themselves. And so when they looked at those, or at least not initially, and so once they had this kind of excellence appraisal, then they went and looked at each of these individual software as a medical devices, they're called, which they should be in the test phase of it now, where they're actually looking at real world, you know, we have to probably define what real world data is, or real world performance is. But there is guidance on how, in theory, a company can take a model to the FDA for regulatory clearance. But maybe having, they used to have maybe webinars or more informational sessions with whoever is interested. Maybe that's a point that we can recommend, to say, to maybe hear updates on that as it's being progressed and things like that.
One other thing I think is important to note is the issue of biosimilars, and the problem is that you can test and train a model and get really good accuracy, but let's say your question is, let's just take, for example, a simple tumor versus normal. Okay, there are some tumor versus normal comparisons that are very easy to make. Okay, and these are usually the ones that people select for their data. What we need to do, at least from the AI perspective, is make sure that we have called out and know where our limitations exist. So if I say I can catch tumors versus normal, but my tumor is all like 90% of my slide, that's a lot easier problem than 0.1% of my slide being tumor. Right. So we have to call out, and I think this is why we really need the community behind it to say, what is it that we don't know? It's important that we know where our limits are. Does that make sense?
Yeah, of course. There's this idea of, I guess it's maybe similar of like label leakage, where if a cancer center is training their models and they're not really looking into the proportion of their or the numbers of their cases and the proportion of their labels, then if they were to train a model and then go provide it to some community center, if they didn't undersample and normalize the distribution of all of their cases, community centers are probably going to have an increase of or a disproportionate amount of what their cases are being called as, we'll call it tumor or whatever it is. So it's kind of a similar understanding of or guidance on how to even normalize the data from the get-go, so that way we can create QA steps or normalization steps of data, so that we're not training, that we're training based on maybe the clinical incidence of disease or however proportion, on the correct, whatever the word correct means, but the correct proportion of the intended detection or support of that model. That's maybe a good recommendation to put out there.
Yeah, I guess I was thinking, coming at it from a different angle, but I was actually thinking, well, what happens if it's a tumor versus normal, and I give them a benign lesion? This is going to happen in clinical cases, but if your model is only trained tumor versus normal, you don't know what you don't know, and that's important for, especially as we advertise these AI models. People have to learn that they are not magic. They have limitations, and we have to know what they are.
I see. So essentially, like inclusion, exclusion criteria of if somebody's going to clear a model, and it specifically has to put a label insert to say we are only claiming detection on X, Y, and Z, but for instance, say we can detect breast cancer, but if some other benign lesion or even other atypical lesion that the model wasn't trained to detect, then we're not claiming, the pathologist will still need to look at the tissue and know that this is not what its intended purpose was cleared for.
Yeah, I think
that's completely great.
Yeah, it's also another way to approach it is like thinking about the type of model that you're actually training. So in other words, like the model should have some idea of like uncertainty in its predictions. So, maybe it predicts something with high confidence if it knows what it is, but if it's something like you mentioned, it would actually, the prediction would be not only like a classification, but also like a confidence level in that classification, which then, the pathologist or whoever who's looking at it, that's like an extra point that they can use to interpret like the output of the model.
So are you saying, so I feel like we're trying to really create a blueprint for a package insert almost. So in lab medicine, they have each of the instruments essentially or each of the tests comes with some sort of package insert that has the defined sensitivity, specificity. It goes through all of the analytes that are, or the sample, the inclusion samples that are required to be tested on, and essentially the output. So I feel like the community at large, or I guess is what we're saying, the community at large would benefit from kind of a prescribed package insert to a certain extent, where whoever's, whether it's regulatory or industry or whoever is providing claims for a specific intended use, that it's very clear what that intended use is. And like you're saying, I mean, I don't know that everybody, I mean, they should provide some sort of confidence intervals, but are you saying that you would exclude binary outputs without any sense of understanding of how, like, what the probability of their prediction was? Or is that what I understood from you, Jacob?
Well, I'm just trying to get at kind of like, yeah, I think what you're saying is great, like in terms of providing, an insert or whatever for the pathologist. But I'm thinking that also you could, work with the people who are like training these models as well, and thinking about not only like how do you like guidelines for implementing like in the lab or whatever, but maybe also guidelines for like what types of models we should be using, like you can choose models, like different model architectures and like ways of training them that are like more or less interpretable. And maybe in the context of pathology, it'd be like interpretability is, more important. So there could be some guidelines for like what types of models we should be thinking about using in the first place.
I think that's a lot harder sell, because the advantages of some of these more sophisticated algorithms are that we don't really know how they, or we can't perceive the level of detail that these machines can pick up on, right? So you are going to limit yourself and your ability. So I'm never, according to that, I'll never be able to predict survival for someone who had early drug exposure if I'm looking at a histology slide. But we know that there are examples where, well, actually, there is something. And you got to remember too that model interpretability is a huge field and it's constantly changing. And I don't know how we're going to keep on top of it.
Yeah, I would agree with that. I think some of what these types of tools offer are things that we can't interpret today, and we don't even, may not even know the certain, I don't know, digital prognostication exist based on angle of tumors infiltrating in stroma. I mean, those are things that people have actually correlated with survival, and that's not a human interpretable factor. I mean, no pathologist will be calculating angles of invasive glands and things like that, especially not at scale. So I would agree. I mean, I do agree that to the degree explainable AI is an amazing field and will help interpret how, I don't know, clinically or meaningful insights or recognizable insights from how medicine is practiced today. I do think there's probably an even larger field, and a lot of the bets on AI are that they do have these unexplainable features that we're hoping can help better our patients. But to that point, there may need to be something, whether it's interpretable or not, there should be some sort of explainability of how the model was able to achieve its intended output, and be able to kind of backtrack and have some level of, like they should, I mean, I don't know if they need to publish the exact machine learning architecture, but it should be reliable and consistent, so that if the same images were run across, if the same model was run on the same images, that it should have the same output essentially every time.
Well, but let's not confuse the reproducibility with correctness.
Yeah.
Right. No, that's true. Yeah, as long as it's reproducible.
Yeah, I mean, I totally agree with everything that you're saying about like, you may not be able to interpret like the features that the model is looking at, but I was thinking more of like in terms of like, what does the model output? Like if it's just a binary classification, like, and it's just predicting yes or no. That's pretty different than if it's giving, some sort of confidence band of its prediction. Like if it's predicting, 0.99 tumor, then that's maybe useful information for the pathologist to know that that's different prediction than maybe like 0.51, for example, where it's like there's different degrees of confidence that the model's outputting. So that's kind of more of what I was trying to get at. But I agree with everything that you guys are saying with interpretability maybe not always being possible in all cases.
No, that makes sense. So you're essentially saying at least being able to provide some probability. I mean, some people are using heat maps or some other form of, whether it's a visualization or even just the numerical value of what is the model's confidence in its output, essentially.
Yeah, I
I
mean,
think that's
there's a
fair.
lot of different, yeah, I mean, that's one way to think about it. Another way is like, setting some threshold where like if the confidence of the model is below that threshold, it just won't give any output. Like the way models are usually constructed now is like it'll just predict from like 0 to 1. And if it's above the threshold, it'll do one class. If it's below, it'll do the other. But like maybe if it's right around the threshold, we don't want it to actually try to predict one class to the other. Maybe that's actually worse for the pathologist. I don't know. These are just, I think,
Um,
things that like
So
guidelines
that
would be
there's a
helpful.
similar corollary in genomics and in molecular genetics, because let's just say the genome, calling variants in the genome is relatively easy and you have high accuracy. You've got like 99.9% accuracy. But there are certain areas in the genome that are very difficult to call it. And especially when you have indels versus SNPs, all of that probability sort of changes. And now it's not that you're 99.9% accurate. It is, if this is the overwhelming majority of your data, then you're good at that. But for these others, you kind of stink. And that's kind of where I was getting at, is knowing the limits of your model, what it can and can't do. Because even with that 51 versus 99% probability that it's class A, right? If it's only ever seen class B and class A, and it's actually class C, your model is going to be very, very confident and still very, very wrong.
Yeah, so I guess we need to think about training models that will know to not be confident if they're seeing something that they've never seen before. That's one way you could think about it. Yeah, I totally agree with what you're saying.
That's a good point. But yeah, but then, or maybe, so I'm trying to think of this from with a regulatory hat, because there's two different faces to this coin, right? One is the regulatory, where the government so far is still planning on clearing specific model, or models for a specific intended use, and that the government doesn't prescribe how, say, an industry vendor comes up with a model, right? They say, show us your data, show us that your data represents a specific clinical class or specific clinical or specific intended use, and do your results back up your claims? And if so, then that model may get cleared, right? At least that's what happens in radiology. That's what happens in other disciplines. We don't have any AI clearances in pathology just yet, but from the regulatory perspective, they just care that the vendor did their due diligence and with some guidance was able to prove that their data matches their, or that their results match their data. So I don't know that we should be prescribing things saying, I don't know, you can only use ResNet, or you can only use certain machine learning architectures, or you should only, or you only have some certain threshold of a probability to actually say that your model is acceptable for practice. because that operating point will probably change based on the intended use. So like maybe searching for microorganisms is, I don't know, you want some models to be more sensitive for screening, you want some models to be more specific for diagnostic purposes and things like that. So, but at a minimum, we can probably recommend to say in this, quote unquote package insert, provide your models sensitivity, specificity at the operating point at which it's currently operating. We don't really have like a continuous learning thought process yet, right? So far, all of these models from regulatory perspective are still being cleared in what's called inversions or at a specific operating point. So then version 1 will have a certain sensitivity, specificity, area under the receiver operating curve, etc. And then it's based on claims. You have to use whole slide image maybe from vendor X, Y, or Z, and this is your claim that it can, let's say, detect this type of tumor, but it can't. I don't know how. So then, some of the early discussion was saying, well, they should also say it cannot detect, and then list out. I don't know what type of laundry list will come out of those, but it'll at least say we claim detection on this, and these are all of the model performance metrics at this operating point at which we're releasing this model and we're requesting clearance for. And then there's a whole algorithm change management protocol that if you were to update that, whether it's updating because you've trained on more data and maybe you have a better sensitivity or specificity, or you're changing the intended use, there's a whole algorithm change protocol that would maybe need reclearance. And then there's the whole implementation, validation, performance monitoring from the professional societies that we probably need to think of recommending.
Yeah, one of the other things is, and I don't know how to do this in practice, but somehow getting to the point where we can measure a goodness of fit of our data relative to the assumptions that the model's making. So given, if you knew the parameters of the data, the training data set, how well does your new item actually reflect that input? Because otherwise, if it's different, then all your assumptions are invalidated. And I know that's the point of usually itemizing these things, but if these, I think we are all aware that you change a step in your laboratory process, and now your stains are a little bit darker than they used to be. What does that actually do to the model?
Yeah, we don't have any way of calculating that or understanding that today, right? I mean,
right. I'm not aware of any. I would like to, but
yeah.
I mean, maybe from the regulatory perspective, that's something there could be, some measure of not only like the model performance, but also like model robustness has to be above some threshold in order for it to get approved, and then develop some way for measuring that by like, I don't know, testing, a bunch of different stains, a bunch of different scanners, and you say it has to perform, within specification in like all these different settings in order to be approved. That's maybe one way you could tackle that potentially.
Like how to disqualify a slide. Really?
Yeah.
That's what you're suggesting, Jacob?
Can you elaborate on that a little bit?
Well, I mean, so we've got these standard procedures, and they're pretty easy for people to pick up on. That if you're given an input, you should get your desired output. But they don't always capture everything. So if we knew, for example, and just this idea of something downstream or upstream in the pipeline has changed, and now your slides are just generally darker. Can we just require that there has to be some sort of check in place that accounts for some of these changes, or at least validate that they are in no way affect the outcome. I mean, and I know that depends based on your classification. You know, if it's just a small AI helper sort of thing versus if someone's going to go into surgery or not. You know, those risks are accounted for in the software as a medical device category, but.
That's a good point. Essentially, I guess what you're both saying is being able to, it is checking robustness, or at least somehow having.
Yeah, it's robustness of the data and robustness of the model.
Right, exactly, and having.
You're learning the hyper. You're learning the space around in which your model and data belong.
Was trained or validated, or that it compares to, and that if the stain variation somehow falls outside of what the model was trained on, that it recognizes that, and like you said, maybe says out of limit of detection or something like that for this, or unable to have prediction on this slide or on this type of data.
Yeah, I mean, I think that's actually like ties in with what we were talking about earlier too, because if you aren't thinking about these things, then maybe you give like a really dark stain slide to a model and it'll just throw off the model for some reason, and it'll give totally the wrong prediction on the basis of the stain or whatever being outside of the parameters of the data that it was trained on. So that kind of gets back to having systems in place that the model will know if it's looking at something that it's not able to make a good prediction on. So I think maybe it's connected.
Yeah, I mean, there's a lot of things from lab medicine I think we can learn from. They essentially have kind of sample rejection criteria and things like that. The difference is you have technologists who are running those tests versus now you're asking the model to inherently know to reject based on maybe the certain vendor of the whole slide image, or maybe some stain variation, or who knows, tissue type, right? So how does the model know to run or not run on that specific slide, right? Which is, we don't have a way of doing that today. I mean, I think the best certain vendors are doing are trying to base it off laboratory information system data. If we think about lab medicine for some point, there are all sorts of machine learning models that are using clinical lab data. I'm talking about like red blood cell counts, white blood cell counts, other types of data that exist in the EMR, right? So these are not just imaging data, these are other data that they're trying to predict sepsis, or they're trying to predict the length of stay, or acute kidney injury for these patients. And they're trying to collect all sorts of data from the electronic medical record, or better yet, the laboratory information system. And I think all of this still very much applies, where maybe, because there are different reference ranges across different populations, across different hospitals, across different tests. So maybe reference range, maybe if a model was trained on a specific reference range, that it rejects other reference ranges unless it was recalibrated within those reference ranges at a local site. I mean, there's so much left we still have yet to do, but these are the types of recommendations or things that we need to think about, because otherwise models will start getting implemented and who knows what will happen. And we want these models to actually be effective in our practice rather than just being hyped for for some time.
Yeah, and that's the thing that worries me the most, is that AI is a shiny object right now, and I worry that there's going to be some claim, and there's this tool is going to predict everything, and it's going to take your life and make it so much easier, but it could actually get you in trouble if you end up relying on it too much, because it hasn't been well supported, validated, and understood.
Yeah. Then.
So how do we prevent that, at least from the AI side? How do we prevent that sort of risk from taking place. And I think we're on the right track with figuring out, I mean, even though we're not going to define what are the acceptance criteria, right? But just saying that you have to figure out what sort of parameters justify the use of this piece of data for this particular model that addresses this particular clinical question so that you fit within the whole regulatory paradigm.
Yeah, I mean, maybe there's, going back to the idea of like reference range, maybe there could be some kind of like reference range for like the training data that a model was trained on, like somehow capture that in like some distribution and say that, you know, any sample that falls outside of that distribution, not represented in the training data, so we don't want to evaluate the model on it. That's maybe one way, maybe similar idea.
Yeah, I mean, it could just be, the thing is, we can't really define what they all will be, but I mean, you can think of basics like, do you have enough tissue? You know, is your staining consistent with your last 6 times you did this, or 60?
May I ask a question, guys? Do you hear me?
A little
we
bit.
can hear you.
A little bit. Are we talking now about clearance? So basically clearance of some kind of product, or are we talking about real world application of such products? Probably about clearance, because we don't have any products based on AI, for example, in pathology. And I mean, there are several different applications, and I think the most promising for clearance are now purely diagnostical application, not kind of survival or something like that, really diagnostical, tumor or not, grading, that's all. And I think they are actually the situation where we, based on the evidence from publications, really know they can perform well. And I think there was also a kind of point of discussion that we can maybe advise or suggest a kind of spectrum of algorithms which can be used. But I think there are lots of algorithms, and when you see these publications, you can probably say that algorithm is actually only 2 to 5% of the accuracy, and mostly it's all about training data. And so I think that when we talk about purely diagnostical application, of course, if I'm producing some kind of algorithm and going to sell it and would like to have clearance, I will have to show my training data and have to give basic metrics. Who did this, or who created this ground truth? It should be, of course, pathologists. Probably, I don't know. You know this. Maybe Matthew knows this well, with multiple instance learning, like pages based, you know, maybe you don't have really pathologist made annotations, but you will have to show in all details your training data. And for example, for diagnostic application, I think it's probably clear for now, they will take some place in the pathological routine, and the problems are actually largely known. What are problems, or what are the problems which can arise? And I think that these problems stem from pre-analytical variables like artifacts and heterogeneity, and they stem from scanner system. For example, we tested almost all scanner systems, and you know all these scanner system. For example, Hamamatsu makes images a little bit darker, and a new Leica scanner GT450 makes them a little bit fainter, and 3D Histech makes them the colors very juicy. And you know everything about the scanners already. And I think probably most important metrics you will have to show about your model is like what kind of errors your model make, because some errors are really critical, like false negative results, and false positive results are actually not critical. For example, for me as pathologist, and I work with several models which are actually very accurate, and sometimes I would like to have more false positive results, not just highlighting the tumor, but highlighting the regions which I, as pathologist, consider suspect. So false positive results are of no problem, but false negative results are really a problem. And I think that One other problem is that many models work not on the region level, but on the core, on biopsy core level or slide level. And I think when you analyze in details this kind of prediction, you see, for example, there is a large tumor region, and maybe it's detected as tumor and slide is tumorous, but there are many false negative results in this tumor region. So I think that actually for clearance, you would like to have some kind of pipeline or stress test of the model. And of course, this pipeline will consider to have a large data set consisting small data sets from different institutions with different stainings and everything, which can be just used to perform this stress test with artifacts. For example, artifacts, we made a large study now for just synthetically generating more than 10 types of different artifacts, and every of these artifacts could lead to deterioration of the accuracy. And I mean, these artifacts, I see different cases every day, and they are full of artifacts like everything, slide thickness, or cutting techniques or stainings, everything. And I think maybe some of the artifacts could be synthetically generated on the completely normal images, and some of them will you can just take slides with artifacts and see how the model works. So I think that basically for clearance, we will have to define the structure of this pipeline, of this stress test pipeline, for which will be necessary for every model which undergo such clearing procedure. So maybe it's better to concentrate on description of this kind of test, comprehensive test, like and maybe this test can have several metrics like basic accuracy, specificity, sensitivity, how many false negative errors were made by model. And I think that what Jakob suggested is this uncertainty metrics. Of course, it's not about the thresholds or probabilities of classes of classification. I think uncertainty metrics is kind of internal metrics. There are different, I think, 6 or 7 different common approaches to extract this uncertainty from the model. And I think uncertainty is really very important, because the situation when the model fails silently, it's very dangerous. So the model, if it fails, it should give a kind of signal that yeah. And I think, for example, in our experience, I think that quality control step will be absolutely necessary before you just let the model analyze any slide. So QC step should highlight all regions which are affected through artifacts, for example, through staining inconsistencies. And I think that quality control step is just absolutely necessary. And maybe one other point, if we talk about real world application, how I as pathologist would like to implement kind of already cleared model in my institution. I think it's maybe not so hard to do this, because we have different pathology, different digital pathology guidelines like Royal College of Pathologists or CAP and everything. And for example, in Royal College of Pathologists, you have to give human pathologists 20 or maybe 30 slides in the area, for example, of genitourinary pathology or something like that, and pathologist has to show that he can or she can diagnose tumor or maybe different conditions in digital setting. And optical, so without any hard discrepancies. And I think the same test can be implemented for AI-based models. So you just give from your own institution, maybe from different years, to account for this staining inconsistencies. You just give 30 or maybe 50 cases, and if model can provide high accuracy analyzing these cases, and you can implement it in your institution. So it can be very similar to what the pathology is actually doing to work digital, like this typical guidelines. Yeah, there were some points, guys.
I think we all completely agree with everything you mentioned. You make great points, and even more, I want to add to those, saying, we talk a lot about the robustness of the model, and I completely agree. When a model fails silently, it may be very dangerous. I think we don't really have good data or studies that look at how the model's predictions may actually affect pathologists' decisions, right? I mean, this is a whole new field of, uh, a pathologist can order an immunohistochemical stain or can order some other lab test for them to use as just another test result for their own interpretation. But if say there is a false positive from an AI model's output, will that affect the pathologist's decision to overcall something? I don't know. We don't really have. I mean, in theory, the pathologist will have training and has all sorts of understanding of what the correct tissue may be. But in some instances, the AI is actually being touted to somewhat democratize medicine or democratize pathology, and also help maybe to increase accuracy at maybe some other community centers or other places if they're being trained on so-called expert data and things like that. So it's kind of twofold, where there's this expectation that AI will help increase the accuracy of pathologists, but then for the times where the AI has false positives or false negatives, how will that impact, let's say, even an expert pathologist's diagnosis? And I don't think that we have data on that just yet.
Yeah, but there are many aspects of interaction between pathologists and some such kind of system. And what I notice for myself, that you start to trust these systems very quickly. So when it gives 5 times proper classification or kind of proper answer on your question, then you start to trust the system. And I think these are completely psychological aspects of this interaction. But at the end, for example, I'm from Germany, and maybe it's a little bit different in America, but I as pathologist is responsible for proper diagnosis, and I will have to overcome these psychological aspects of trust and everything. But I think that most important, the basic metrics. When you have a test data set, which, for example, which will be created through FDA or some kind of organization, and will contain a lot of slides from different institutions, really heterogeneous data set, and you can, as first step, show that your model is highly accurate on this data set. I think I will only then start to think how it will help pathologists. So I think the first step is always to show in the large independent external validation data set, test data set, that that there are some basic arguments for consideration of your model as real pathology tool. And I think that this kind of test and this kind of independent data set will be necessary just to make sure that your model can do this. And later, I think the studies will be necessary, how these interactions look like and how it helps or not helps the pathologist. But I think there should be some basic high accuracy result at the first step.
Yeah, we have a long way to go. There's definitely a lot I think we still need the evidence for and data for, but I do agree that so far today, and probably, if we do get our first cleared pathology AI model, it'll be some sort of diagnostic detection or some other decision support tools or similar decision support tool that's been validated. Again, from a regulatory perspective, at least within the US, the FDA only really clears models based on their specific intended uses, and if that specific vendor essentially showed that they were able to match their claims with their results. So I think it's very different than what we're talking about in our sense, trying to really put forth some other best practices and even I guess basic definitions, if you will, for how we feel these models should be either generalizable or more introspected based on their confidence. And so I think we can maybe put out some guidelines or we could recommend accreditation bodies to put out some guidelines, but also put out some, as maybe even a white paper on kind of best practices for how to release an AI model into the wild, so to speak, or make one available by putting out all of these things that we've been discussing. So I thank you all for all of those points. I think I think there's some things we all agree on that would be that we can concretely agree on, at least, that would be very helpful for all of the researchers and vendors in this space to hopefully comply with. And this is essentially how we voice all of our concerns, is by putting them together in some sort of document that can be distributed from within this collaborative community. And I think we're all getting kicked out of this room in just about a minute. So I'll wrap up with that. We'll probably go over and summarize this in the next session altogether. So please feel free to interject with anything I summarize. But with the last 30 seconds, I just appreciate your discussions and thank you.
Yeah, thanks for the discussion. It's very interesting.
That's great. Thank you both. I guess I'll see you back in the other room.